All right, gang, we are going to continue and move forward as we hand over the stage to Alison Noice, CODA's Deputy Director since 2014, directed CODA's addiction medicine programs for 4 years prior to that. She's worked exclusively with underserved and indigent populations since moving to Multnomah County back in 1999. She studied clinical psychology at University of Montana, received her Master of Counseling from Pacific University. In 2016, Alison received her graduate certificate in healthcare management from Oregon Health Sciences University, and she's a rock star. To boot. Please welcome Alison Noice.
Thank you. Thank you. I can't help but put that graduate certificate on there. It's a little silly, but when I finished graduate school the first time, I thought for sure I was never going to do any of that ever again. So it was just kind of fun. So I really love to talk about medication-assisted treatment. The folks who are in the room who may have seen me do this before know that about me. I also really like to entertain questions. So really hoping to be a little interactive as best as we can with the time. We've got some time for a panel, I think, later, but I'm going to make Paul earn his keep. Or you're going to make Paul earn his keep. We'll see. So pretty simple agenda. For my portion today, I've done a lot of these talks, and for those of you that know CODA, you might know CODA almost exclusively as a methadone clinic. We do a lot more than that, but that's sort of often what people think of when they think about CODA. So having run that clinic for a long time and having learned a tremendous amount about what a clinic like that is, who it treats, how it works, I feel pretty strongly about opportunities like this one to just talk real openly about what clinics like those are, what they aren't, and give people opportunity to ask questions about them. There's a lot of rule behind how programs like ours work in outpatient and dispensary settings, so there's a lot of good opportunity to just sort of dispel some myths and talk about some rules that are pretty arbitrary to the outside viewer. And hopefully what we'll accomplish today is also really thinking about how we can change the way we think about patients with opioid use disorders who are likely to benefit from medicines, and how we see and are participating in the community landscape changing in the way that these treatments are offered to our patients. So we talked a little bit about the medicine, but I like to be a little bit more detailed kind of practically about what they are and how they're the same and how they're different. Again, questions are welcome. So methadone you will receive for opioid use disorder only in what we call an opioid treatment program, or an OTP. You heard Andy use that term. It's not exactly common knowledge, but it is the preferred terminology for a methadone clinic. There's lots of reasons we prefer not to call them methadone clinics. Tons of stigma, and pretty narrowing in terms of a description of what that clinic actually is. An opioid treatment program is licensed and able to provide medications, any medication that is federally approved for the treatment of an opioid use disorder. So an OTP can dispense methadone, an OTP can dispense buprenorphine, an OTP can dispense or administer naltrexone or injectable naltrexone. What's very true about an OTP is it is buried in rule and regulation. So while I think OTPs have a bit of a community belief that they are sort of fly-by-night operations that just like shove medicine out the door and let people use drugs or don't communicate with their partners, some of that's earned. There's actually a lot of federal oversight that really is what governs an opioid treatment program. So an OTP is federally licensed. We are DEA licensed. We are state licensed. And we are separately, independently accredited. OTPs are required by the feds to be accredited by either a Joint Commission or CARF. So that's a lot of people with a lot of regulation that define who we treat, how often we treat them, every single drop of that medicine that comes in and goes out, and who dispensed it, and who signed for it, and what time of day, and every little bit of it. So there's a ton of regulation that goes into citing and operating an opioid treatment program. It makes them fairly expensive to run, and they're not easy to cite in your neighborhoods, as you can imagine. The Portland metro area has quite a few, but you get outside of this tri-county area, and it's a bit of a wasteland. Methadone you can only get in an OTP. That all makes sense so far?
Methadone
Great.
you can only get for an OTP for opioid use disorder.
Yes, thank you. Medical providers can use methadone to treat pain. OTPs can use methadone to treat opioid use disorders. OTPs don't treat pain. Medical practitioners don't treat opioid use disorders with methadone. How often do you think those populations overlap?
The union there is about 80%.
Yes. So obviously our patients often come to us with chronic pain. They do receive benefit from the medicine while we're treating their opioid use disorder. The lines get a little blurry. Buprenorphine, for those of you who aren't actively connected to practices that prescribe it, you will hear bup, you'll hear Suboxone, you'll hear Subutex, you'll hear buprenorphine naloxone. The standard of care is buprenorphine naloxone. It's a combination formulation that is buprenorphine's the active medication. Naloxone is just there to say that again? I can't. So naloxone's there so people don't crush and snort and hopefully not divert it. It has nothing to do with overdose reversal, just for the record. There is dramatically less regulation around buprenorphine than there is methadone in opioid treatment programs. That was a good intentional move back in the early 2000s. It was clear that a lot of people needed access to medication-assisted treatment, and OTPs are just not necessarily readily accessible all over the country. And they're limiting in that they require people to show up every day. The idea behind introducing buprenorphine was that more people need access to treatment, and let's try to figure out a way that they can do it in a more discreet and sort of more patient-friendly environment. We didn't exactly see that take off. We saw it take off for a second, and I think providers had a pretty negative experience with it because they weren't accustomed to treating substance use disorders in primary care. See Andy's 1 hour of addictions training and his medical schooling. So it sort of got introduced, people got their data waivers, a lot of people had pretty bad experiences with it pretty quickly, and then a lot of people said, nope, not for me. So here we are today. We need a lot more people who are interested in prescribing buprenorphine, who are actively prescribing buprenorphine, and I think we have a lot of work to do to really make our provider community comfortable with it. Hence, rooms like this. I need to change that slide. It is not buprenorphine is not exclusively physician prescribed. It is now physicians, DOs, NPs, PAs, nurse midwives. Buprenorphine, again, you can get in a methadone clinic and you can get dispensed on a daily basis. So that's an important thought for later. Are we all there? All right. Naltrexone, indicated for opioid and alcohol use disorders. Obviously, if you're going to get it in an OTP, it's to treat the opioid use disorder. We're finding lots of people in our outpatient programs are enjoying it, responding well to it for alcohol use disorders, but to Andy's point, we have not seen it take off for opioid use disorders. I like to say that, particularly the injectable version of naltrexone, otherwise known as Vivitrol, I like to describe it as the medication that the people who sit around tables and decide for our patients what they should get, they really like naltrexone. Child welfare really likes the idea of naltrexone. Pearl and probation really likes the idea of naltrexone. Our patients don't like it. Yeah?
Where are we at on whether or not naltrexone is beneficial for methamphetamine use too? Because there's been some research on that.
Yes. Is naltrexone beneficial for the treatment of amphetamine use disorders? How badly do we all want a medication to treat amphetamine use disorders right now? Oof. There are some studies. CODA's research department, which we're quite proud of, has been a part of them, that has been evaluating the efficacy of naltrexone in combination with bupropion, Wellbutrin, to good result. So it was using injectable naltrexone and Vivitrol, which obviously at this point our payers is not indicated, our payers are not paying for the treatment of amphetamine use disorders. But there we are, and that sounds promising. Andy, do you have any other exposure to that, or?
Just anecdotally, I think most importantly, people are asking all the time, isn't there something for this? Right?
Yes.
And I got an email from somewhere in rural Oregon about that specifically, but I look forward to seeing what the Clinical Trials Network that CODA is a part of publishes. So it's exciting.
Yeah, it's very exciting.
Can I ask you a question on that?
Yeah.
Where are they doing that clinical trial?
Uh,
Is that something that
CODA?
is that in Oregon? Are you guys doing it?
Uh-huh.
Can I
We're recruiting.
suggest
I believe
someone for
we're
you?
recruiting subjects still. I'll double check. But yeah, I can. I'll see if I have follow-up information to distribute.
Awesome, thank
yeah.
you.
Yeah. I hope we're still recruiting subjects. Wouldn't that be terrible? I'm so sorry.
Hello, Alison. Are you going to address whether it's possible to convert from methadone to the Subutex or Suboxone and how that works?
I'm not a physician, so I won't describe to you how to do it, but I can speak to sort of what our experience is of it and what we recommend for our patients, and
helpful. Yeah.
there might be
Since it's so much more accessible than the methadone.
Yep.
Yeah.
Yep. Okay, so naltrexone, methadone, buprenorphine, naltrexone. Other questions about the medications themselves, where you get them. We'll get into where you get them in just a second. Yeah.
What is it about naltrexone that the patients
Let me get you on mic just if we have
Yeah.
questions, just so everyone can hear.
I'm moving around so much for the cameras. I'm so sorry. So why do our patients not like naltrexone?
Correct.
I think a couple of things, and again, these are just what our patients are telling us, either with their mouths or their feet. The effects that it has on cravings for alcohol and desire to use alcohol just feels more effective. We have patients who just don't. It does impact cravings, but it just doesn't. It's a different mechanism. It just doesn't seem to land the same way. But what I actually argue from our experiences, I think, and again, this is a largely behavioral crowd, which is great. We know that motivation is multifaceted and shifts by the moment sometimes. So I think when you're talking to a patient who is ambivalent about whether or not they want to quit using opioids and everything that goes along with changing that behavior, to expect somebody to be like, yep, I'm in it to win it. For the next 28 days, 100%, I am okay with the fact that I'm never going to be able to use an opioid and have any kind of effect. And not only that, but like in 28 days, I'm going to come back and do it again. And I don't think behaviors change that way. I think it's a tremendous amount to ask of a patient. And for people that don't sort of really get the turmoil of recovery, that sounds like, well, why would you not want that? That's why I say the people that make decisions for our patients like it. There's something else I was going to say about that as well. But that's what we see. It's why we see a lot of drop-off.
Is there a preference as to why the shot versus the pills? I mean, granted, I see a certain population that would benefit, but
Right. So
as effective?
Again, just kind of an anecdotal answer. So why do we think the injectable version might be better than the oral version? So naltrexone's an opioid blocker, right? So once it's in your system, you can't get any effect from opioids. It leaves your system fairly quickly. So for a long time, we kind of abandoned oral naltrexone because it didn't seem like it was working. Well, the reason it wasn't working was because people don't take it. You have to take it every day. to get the benefit from it when you're just using the oral tablet version. So again, motivation is fleeting and complex. If I have to take a pill every day that says, today I'm not going to get high, today I'm not going to get high, today I'm not going to get high, what do you think I'm going to do when I feel like I want to get high? And not just want to get high, but like just, become overwhelmed by everything that is behind that behavior. I stopped taking it. So the injectable version has tremendous benefit, sort of conceptually, for that reason.
But effectiveness, if they do take it every day, it still works.
Yes. Ish? Yeah. Okay, cool. I love this. This is great. So we talked a little bit about the medicines themselves, and I want to really dial into this idea about settings and thinking about settings as levels of care. So again, opioid treatment program, formerly known as methadone clinic, is a place that is specifically designed to dispense medicine every day. So what that means is a patient who enrolls in treatment in an OTP comes in every day, except for Sunday, let's say, and gets in front of a nurse who puts eyes on them to make sure they look okay, asks them some questions, gets them to talk to them, sees them every day, so knows very well what their baseline looks like, right? Has a relationship with that patient. I get to see that patient every day to see how they're doing. I don't know any other behavioral health setting I've ever worked in where I had the benefit of understanding my patient that way, of having that opportunity to interact with them. That's huge. And I think that's a really important thing to appreciate about OTPs because of how sort of maligned they have been for so long. There is real value in that type of treatment setting. And I think something that we could be taking advantage of as a treatment community, particularly because we know residential beds are finite. There is, varying efficacy of residential for a lot of folks, and some folks literally cannot pick themselves up and put themselves in a contained treatment setting for 60 days. So what you have in an OTP is this hybrid of not quite residential, but the real capacity to put some real intensive support around a patient. I think that's incredibly valuable. So the way an OTP works is you come in, you enroll in treatment, we see you every single day. We collect urine, collect a lot of urine, I gotta tell you. Sometimes more than I think, but it's fine. There's access to case management and group counseling and individual counseling, and again, that medical eyes on every single day. And then as patients get stable, the federal rules, again, remember there are many, sort of define at what point people have to come see us less frequently. So we have this very intensive relationship with a patient. As they stabilize, we sort of back out because the goal of our treatment and of recovery is get away from us and get into your community. Don't be here, be there, be connected to supports. Your recovery is away from us. But we have that capacity to sort of expand and contract that relationship depending on how stable somebody is. So pretty fantastic place to work in my personal opinion. Office-based treatment, right, is sort of what most of you guys presumably are doing or familiar with. I go into a clinic, I see a practitioner for a counseling session, I go to a group, I have a relationship with a physician or nurse practitioner, I meet with them, they write me a prescription, they send that prescription to the pharmacy, I pick it up. Ideally, that means I'm the kind of person that can manage a 7 to 28 day supply of medication independently and safely. So if you think of these two treatment settings together, now we have this real meaningful continuum that is, okay, I've got somebody who we're going to try the sort of least invasive opportunity, treatment intervention that we can. We're going to put you in an outpatient setting, office-based, OBOT, which we call it, and we're going to test it out. And typically what happens when somebody comes into an office-based setting like that, they see a physician in our behavioral health settings, pretty traditionally, they see somebody once a week. So we get you onto the medicine, we start you out, we've got just a 7-day supply, 7-day supply, 7-day supply. And then ideally, you stabilize, you stop using illicit substances, participate in treatment, and we start looking at how you're doing in your community, right? And then that might sort of warrant longer and longer prescriptions. And typically the longest it gets at this point is a 28-day script. At some point when we've been doing maintenance therapy in an outpatient environment for decades, maybe somebody gets a 3-month script, but ideal, like right now, largely what you see is maxing out at a 28-day supply.
Do you typically try to taper them with their other opiate use to like a certain, like, because I know like the idea is to try to have patients on less than 200 milliequivalents of morphine a day.
Mm-hmm.
So do you guys try to taper that down and then transition to the bupropion, or because what about like DTs or some kind of withdrawals or stuff?
So buprenorphine, typically people are in moderate, we do typically put somebody onto buprenorphine when they're in moderate withdrawal. So if you're describing somebody who's being, it sounds like you're describing somebody who is under the care of a physician who's being tapered off of a prescribed medication, which Jeffrey and I are talking about how to get better at. That's, to be totally honest, largely what we're seeing are, because we live kind of in the deep end of the pool is how we refer to it, our patients are using substances illicitly, so there's nobody that's tapering anything. So what we're talking about is we're bringing them into treatment, we're putting them in front of the physician as quickly as possible. Our priority is really get somebody in front of the doctor on the same day. I use doctor colloquially. And basically talk them through the fact that they need to be in some amount of active withdrawal before we initiate buprenorphine. Because if they have too many opioids in their system at the time that we initiate buprenorphine on day 1, we'll actually send them into withdrawal. Precipitated withdrawal is what we call that. That's a real good way to make your already uncomfortable patient really uncomfortable and ensure they never come back again. So I find the more familiar providers get with buprenorphine, and frankly our patients are pretty savvy with it at this point as well. The amount of withdrawal you expect somebody to be in our sort of tolerance for that tends to get a little lower. When we first started doing buprenorphine in our outpatient clinic, we had all these protocols set up assuming we were gonna do like on-site inductions. We were gonna see people for 3 consecutive days for hours at a time, because there is literally a protocol that says like you administer, you wait an hour, you check for withdrawal, you administer, you wait an hour. It turns out, and this isn't questionable, this is just reality, our patients know how to get themselves on and off of buprenorphine pretty well already. So we see them, we evaluate them, they talk to us about what their experiences have been, and if we're comfortable enough with them, we say, look, here's a little bit of medicine. Just when you go into withdrawal later tonight, check in with us tomorrow. So it's actually become a much less labor-intensive process than we thought it was going to be. And home inductions are really becoming pretty increasingly established as good practice.
So this is not a safety issue. This is a matter of comfort doing this induction. Got it.
Yep. Methadone, you have to be in markedly is less. Requires less active withdrawal. So we have had patients who just can't, some patients just never get to a point where they can tolerate being in withdrawal, that the opioid use is just so pervasive and the behavior is so automatic that like asking a patient to go into enough active withdrawal to start a medication, they just never get there. So that's sort of when we get into when I talk a little bit about the recommended for population. This is not rule, this is not regulation, this is just our experience with the work. But again, as I talked about what a sort of real benefit the structure of an OTP is, those folks who have really virtually no recovery support, they're often homeless, they have had multiple trials of treatment, they have had multiple years of cycling of withdrawal and relapse and use, and So the folks that really benefit from some daily contact, for all sorts of reasons, we recommend to be in an OTP. Because methadone and buprenorphine are gold standard medications for the treatment of opioid use disorders while somebody is pregnant, we recommend that treatment be housed in an OTP when that's feasible. Again, you have so much nursing support inside of the facility. We actually have in OTP a lot of regulation that requires us to prioritize treating pregnant women and to actively collaborate with their maternity care. So those are very good environments for pregnant women. I will also just plug, at CODA's OTP, we have a program called Project Nurture, which we are just thrilled to death about. There are 3 Project Nurture sites in the Clackamas and Multnomah County area. At CODA, we have brought OHSU Family Medicine Richmond into our OTP. So all of our pregnant women who come in with opioid use disorder get fully integrated primary care, all their prenatal care, they get all this active coordination into the hospital and out again. They have doulas that are paired with them 24/7. They come out, they deliver, their babies are happy and healthy, and we treat their babies for a year postpartum, as well as all of the year's worth of well baby visits and all the postpartum work. It's a fantastic experience.
All those programs are on the east side? Those
Yes. Would you like to talk about one on the west side?
But that's outside of the scope.
But it's been a real tremendous success, and we're hopeful to find a way to continue and spread that program. So folks who are homeless, we often find people, particularly people who have really extensive histories of injection drug use, tend to often just do best on methadone. They tell us often the buprenorphine just really doesn't quite get it. And that's not suspicious, right? There's something that happens where we question our patients who come in and say, I just really want to be on methadone. Or just put me on buprenorphine. And there's often you see this moment, it's like, well, why do you want that so bad? Why don't you want to do it some other way? Because it works. Anyway, so again, those folks who just have virtually nothing to hang on to are the ones that we usually start in an OTP and may transition into an office-based setting if that's appropriate once they get stable, but that's generally what we recommend. So again, the office-based population is that group of folks who's going to show up to an appointment. They're going to come in for their weekly visit. They're going to manage their medication. We're not going to have tremendous concerns about diversion or other sorts of misuse of the medication. And typically, those are folks that have a little recovery capital. They've got somebody that's in their corner. Somebody's encouraging them. Somebody's helping them. They've got something to lose. There's a little bit of something that you can grab onto there. And so at CODA, we've really worked to try to build out this sort of internal continuum so we can really help our patients move as seamlessly across the levels of care as we can and really understand which is best, not just because of geography, but because of real clinical need.
I'm a behavioral health consultant in an office-based opiate treatment program, and I was really struck by the data around the gaps in access and need, and I see office-based opiate treatment as a real great opportunity to reduce that gap.
Yeah.
And so I'm just curious, I want to hear more about why you think patients with a shorter duration of opiate use are best fit for office-based opiate-based treatment?
Like I say, it's pretty anecdotal, and I think, again, if the theme of today is more medicine in more places, that's it. Nobody should walk away from this and go, oh, I've got a patient who's been using opioids for 5 years, I better not even start him. Heck no. So I appreciate you. More medicine, more places. I just sort of really like to take the opportunity to sort of appreciate a continuum of care, but given to Andy's point and Paul's slides, there is so much need and so little capacity. Let's build smart practices in as many venues as we can. Thank you. Good? All right. Oh, I got another one. All right, when I think about adding medication-assisted treatment to my clinic, this is how I feel. Just text a word. First word that comes to mind. Ah, nice. There we go. Yep. All right. Spendy. Overwhelmed, interested, unsupported, interested. Very good. Great. This is, that's it in a nutshell, right? It is practice change. Change is hard. This isn't always the most sympathetic patient population. It's important work. We know it's important work. And it's figuring out where the place to start can be pretty tricky. So hopefully some folks get to walk away today with a little bit more sort of footing and some questions answered, and hopefully some ideas about where we can go next. So stole this from Andy. I always like to show it again. I think it's so striking that, the cancer metaphor in particular is so striking, right? Like, what have we been doing all of this time where we keep asking our patients to wait for medicine? And this is, I sort of appreciate this is about, there are a lot of different ways we can slice this, but what we're doing on a patient-by-patient basis so often is saying, okay, you have an opiate use disorder. Let's try residential treatment. Let's try non-medicine. Do you really need to do medicine? Like, let's try all these other things. And look at this. Our patients on methadone and buprenorphine stop using opioids. Every one of these overdoses every one of these relapses can be a fatal overdose. And yet we continue to tell our patients to try something and try something and try something and try something. And then we say, ugh, all right, medicine. It is the most evidence out of nearly any of our treatments for substance use disorders, and yet we continue to withhold it because we're either nervous about it, because we have some belief that it doesn't mean real recovery, because we're afraid we're going to go broke doing it. There's a million reasons not to do it, but these people are dying. So that's why I sort of like to use this phrase about moving away from fail first. Andy referenced the tip 63. This is, SAMHSA puts out these treatment improvement protocols. They've been making them for years. They're always really nice overviews of interventions and are usually written for a pretty broad audience. And this one that they've written most recently is just probably the best one I've ever seen them write, just in terms of the overview of the medication and the different implications in the treatment settings. I highly recommend you have it in your office. You read it, you hand it around, you encourage people to look at it. And the best thing to take away from this is the fact that what this expert panel is saying is that if you treat a person with an opioid use disorder and part of your very first visit is not, let's talk about all of your options that are medicine along with everything else, you're not doing it right anymore. And I started doing these talks about 8 years ago, and I'm so fortunate and so pleased that rooms like this are so open to medicine in a way that they were not when I was starting these talks. And so 8 years ago, I would come into conversations like this, and I would I'd tiptoe in, and I'd sort of plead our case, and I'd talk about what really good people we were despite all the bad ideas that you had about us. And I'm kind of done with that, right? I think we're past that. It's not okay to sort of tiptoe into the idea of medicine anymore. It works, people need it, and we've got to figure out how to get it out there. So one thing that we did, HealthShare couple years ago, contracted with CODA and Central City Concern to create what became a thing we called Wheelhouse. Super proud of it. It was specifically meant to target the behavioral health system in the Tri-County area. So what we did was CODA and CCC stood up and we said, all right, we know medicine, we love medicine, we want to help other people love medicine. So we will take on the complicated patients, we will enhance our own services and make ourselves as available as possible to our patients and to our community as we can. And then we reached out to our behavioral health partners and said, how can we help you get there? So essentially what we did was we spent a year and a half helping these partners learn about medicine, develop their policies and procedures, prepare their practices to implement. It was a pretty big lift and has been a pretty rewarding but long road. So a year and a half later, we started with an invitation to about 34 providers. 6 of them took us up on it. That tells you something about how excited people are about medicine. But we stuck it out, and now 4 of those 6 are prepared to prescribe medication-assisted treatment. We've helped them implement their practices. We're continuing to support them. We have had such a tremendously rewarding experience with our provider community to do this. We're really hopeful. This is a model that's been used in other parts of the country to success as well. We're really hopeful that we can keep working this way, both with behavioral health and with our primary care partners. So, yeah, question?
So when you say that you have 4 providers, are those solo practitioners, or are you talking about systems like
Organizations. So,
okay, so like LifeWorks, Cascadia,
Cascadia is one of them.
Side, Cascadia.
Yep. Cascadia is one of them.
Can you name other names?
I can name names. So currently ready to prescribe medication-assisted treatment are DePaul, Cascadia. I'm totally outing them. This is no, it's good. DePaul, Cascadia, Outside In. Sequoia is like poised, but not quite there yet. And that's it right now, right? So we're going to keep working with them. That doesn't mean you should blow their doors off, but by all means. They have put a lot of really great work into building out the programming. So, oh, there we go. Yeah. The county clinics?
Yes, they all offer it as well.
So I happen to know, because of some other work that CODA's done with the Multnomah County Health Department, that they have dramatically increased their waivered providers. We've supported some of their clinics in getting up and ready and talking about medicine, and it's also been a really rewarding experience. I want to say they have like 40 providers. I might be making that up. Does that sound right? So they've really had some pretty tremendous growth as well. Our partners, Virginia Garcia in Hillsborough, have been tremendous as well, partnering with CODA in our Hillsborough site to really help people in a continuum of medication-assisted treatment. We, like I said, we do the deep end of the pool part, and then when the patients are more sort of steady on a maintenance dose and have sort of participated in their treatment, we move them over to Virginia Garcia. It's been quite rewarding, if I do say so myself.
There was also the Project Echo, Matt.
Yes. I am not super, does somebody want to speak to Project Echo?
Oh, you okay. I'll be mentioning that later.
Perfect.
As part of our next
Okay. So we had, this short answer is this has been great. It was a really, just as an aside, I've never seen our behavioral health provider community behave so collaboratively. And it was, not to fault anybody, we've been under-resourced and sort of scraping by for a long time, and this was a really impressive coming together of organizations that historically have thought of themselves as competitors, so really cool to be a part of. This is all the great stuff we did. I'm going to skip that. No offense to my Wheelhouse partners here that did a lot of that great work. So just because I want to speak to a couple of things in the sort of changing landscape vein, Andy mentioned, and again, if a lot of you folks are behavioral health providers, you know the Oregon administrative rules. This was a huge shift. So for years, as a provider of medication-assisted treatment, we have been very limited in our ability to get our patients on medicine, into other modalities, particularly residential levels of care. Drug courts in places have insisted that in order to graduate, you have to get off medicine. Sober housing has not let people into their facilities on medicine. So these two shifts are really quite dramatic. There are providers that aren't going to change overnight, and I don't see a ton of pressure to make them change overnight. So I've said it. But it does now say that a provider in our community or in our state can no longer have policies and procedures that essentially prohibit entry of patients who are on medicine or that insist on the tapering off of patients on medicine. So very big shift. Again, in the Health Evidence Review Commission also is insisting that people be talking about therapies, about medication-assisted treatment, and I'm particularly appreciative of the fact that they called out providers must be able to speak to at least one agonist therapy, which, if you remember Andy's slide earlier, agonist therapy means buprenorphine or methadone. So this was really important because what we didn't want to see was a lot of people say, well, we like Vivitrol, so you can have that, when we know that there's so much evidence for buprenorphine and methadone. And the fact that that rule says you have to speak to agonist therapy, I think, was a big win for us and for the patients.
Can I ask you a quick
Yeah.
clarification? So, it's quick. So you're saying that that the rules have changed, but the practice hasn't changed yet?
Not yet. You've got some pretty deep-seated beliefs and organizational practices that need to make some shifts. And some folks, as we saw in our wheelhouse work, some providers are ready for it. They get it. They just needed to know how to do it. Other providers have really sort of pretty stoically insisted that to use medicine is not to be in recovery, and have been very concerned about what it would mean to bring medicine into their treatment environments.
So what do they say when you show them the data?
Not real.
Especially that slide.
I have had people dispute it. I've heard insistence that somebody actually not that long ago asked me if essentially, it was a strange question, but basically I think the implication was that drug companies were sort of responsible for the research, which is not true. They have just frankly said, that's fine, but I don't believe it, or I don't want it. I think they're running out of answers, to be honest. I had a drug court judge a handful of years ago in a not-to-be-disclosed county invite me into their retreat and then literally say to me, I don't know who brought you here, but I can tell you as long as I'm the judge, he's not the judge anymore, as long as I'm the judge, there will be no methadone in my program.
Wow.
And he literally said, I don't care what the evidence says.
Wow.
Andy?
Just to extend on this, I don't think that there's any legitimate reason to ignore the science. And having been all over the country, I'll make this brief, I think that there is incredible risk liability that the malpractice attorneys are now grabbing onto. Mm-hmm. And I worked for an organization that historically used to say things like, but Dr. Mendenhall, we don't do that because this is who we are, right? And I can speak in a very cloistered fashion around the fact that I know that a post-residential discharge death led to a $1.5 million settlement after a family spent, not exaggerating, $2 million on treatment for their loved one over a period of 7 or 8 years. And no medical professional, no behavioral health professional on a discharge summary recommended, after a person brought heroin into a residential milieu, recommended discharge to a medication-assisted treatment program. It wasn't discussed with the family, it wasn't discussed with the patient, because, quote, but we don't do that, right? That is a heyday for malpractice attorneys, that's a heyday for, I'll call that a civil rights violation, right? And I'm really grateful that the treatment network has expanded really to empower patients in a way that they haven't been historically.
Thanks, Andy. So I think that's about my time. Some sort of key points. We talked about fail first. I can't say enough. I can even speak to, as an agency who has used medicine for years, I think we've only recently figured out how to get out of our own way by saying, no, put the medicine in front. We kept waiting for people to sort of earn their way into medicine. Show us how much you want it, show up for all the appointments, jump through all these hoops. Forget that. Give them the medicine, because that's why they come back. And then you get to engage them in all the other ways that we know we're capable of engaging our patients. But the medicine is what's keeping them alive, and it's keeping them in treatment. And so why do we keep putting all these barriers up in front of it? And appreciate, to the gentleman's point about illicit drug use, these medications work very well to manage opioid use. They don't change behavior, they don't change thoughts, they don't change reactions, they don't change my desire to feel differently, so maybe I'll use meth instead. That all comes with the territory. But when they're on medicine, they stay engaged with us, and so we get to work on the amphetamine use disorder. It's not that we're disregarding it, but we're not going to kick them out of treatment because of it, because that gives us an opportunity to work with them. Patient preference isn't suspect. If a patient comes to me and says, I want to be on methadone, cool, let's start there. We talked about the science, I love that. And then you're not in this alone. There are lots of us out there who have done this work, who want to help others do this work. There's no scarcity of resource in this place, right? We have a lot of need, and we have a lot of patients that we have not gotten anywhere near. So let's figure out how to creatively partner. Let's figure out what you need and how we can get it to you. All right. Awesome. Thank you, guys.
Round of applause, guys.